Good afternoon, everyone. Welcome to our symposium this afternoon. Is everybody ready to roll? Had a good lunch? So our symposium this afternoon is Revolutionizing Health in Nutrition, Endocrinology, and Gastroenterology. We have a nice slate of speakers. Our learning objectives for the afternoon are to summarize the various options for assessment of body composition and the pros and cons of each method. We're going to talk about C. diff, describe advances in technology for the treatment of constipation in C. diff, the use of CGM, continuous glucose monitoring, and practice efficient ways to utilize nutrition knowledge and skills through the support of technology. There's a QR code that most of you are familiar with by this point. You can use this to offer suggestions for planning next year.
So after serving 12 years in the military, David Proud graduated as a dietitian in 2003 and has specialized in respiratory health for 20 years, the last 13 years supporting adult people with CF at the All Wales Adult Center in the UK. David leads on supporting his dietetic colleagues as a research and development champion. Within the specialty of CF, David has a particular interest in exploring the potential of body composition assessment in a bid to aid in patient care. With published work on this topic, and he has presented data on this topic and others at several European CF conferences. In 2024, David took over the position of co-chair of the UK Specialist Dietitians Group and is a member of the UK Specialist Dietitians Body Composition Working Group. We're excited to have you, David.
It's exciting, isn't it? This is sort of like part two. So part one, I presented in 2022 in Philadelphia. And so this is sort of like a follow-on. I did fundamentals of bioelectrical impedance and hand grip strength, and then we're sort of like following on from that. And what I want to do today is spend the next 20 minutes looking at technology and the practical application of body composition guidelines. I have no disclosures. So today what I want to do is review a couple of recent published guidelines that focus quite a chunk on body composition. Also looking at the results of a survey that we conducted in the UK as part of the body composition working group across all CF centres, and then using guideline themes from these documents, trying to apply the guidelines into practical clinical care. And then we'll summarise at the end. So the three documents I'm going to refer to throughout this presentation. The first study from 2021, the McDonald's guidelines, and recommendation 7 focuses specifically on body composition. The second article is the European guidelines for nutritional care in CF. And again, recommendations 4 through to 8 focus specifically on body composition. And then the survey that myself and a colleague carried out, entitled Measuring Body Composition in Clinical Practice, is the results of a national survey we had published earlier this year in our professional journal. Starting at the beginning, so what is body composition? So when we're reading the literature, we'll quite often see it referred to as a compartmental model. And we'll see often 2 compartment, which is the most simplest form, where the body composition is divided into fat and fat-free mass. We've then got the 3 compartment model, where the fat-free mass is subsequently divided into lean mass and bone or mineral. And then the most complex that we'll see referred to is the 4 compartment model, where lean mass is further divided into protein and water. We can see as we're going up in the compartment models, we're reducing the error, so the risk of error becomes less, but also there's increased complexity in trying to achieve these goals. The 4 compartment model requires several different measuring tools in order to compile that data. But typically we'll see the 2 compartment model referred to, and particularly in the guidelines, this is what's referred to. And then just looking at the various tools that we have out available. So at the top left, we've got the air displacement plasmography. So this is an example of 2 compartment model, often referred to as BOD-POD or P-POD for children. Then we've got the tried and tested tape measure, and then skin fold assessment, either a single site or multiple sites. And we've got the DEXA, which is considered the gold standard. So this is an example of 3-compartment model. And then we have ultrasound, which is gain and traction at the bottom right. And again, this is an example of at least 3-compartment model. You could say a 3+, because it can differentiate in relation to quality and quantity of tissue. And then we've got bioelectrical impedance, which is a 2-compartment model. Then we've got muscle function, so not specifically body composition. And this is through hand grip dynamometry. And then the bottom left, we've got CT and MRI, which again is an example of 3-compartment model, or 3+ again, because you can see quality and quantity. But we don't really have time to talk about all of the devices, the pros and cons. They've all got positives and negatives to them. What I wanted to do was focus on a few of the tools, and addressing the first question that we had from our survey. We asked all of the CF centres, do you offer body composition as a measuring tool? And of the 36 centres that responded, 16 actually offered body composition as an assessment, which was 44%. We then asked them what tools they used. All centres offered more than one type of body composition assessment, depending on the situation. But the most common by far was bioelectrical impedance, with 12 of the 16 centres using this tool. And then the second most common was described as other here. They were all hand grip strength. So this was 6 of the 16 centres offered hand grip strength. So for the purpose of the next 18 minutes or so, we're going to focus on these 2 tools. And then the first guideline theme that I want to look at is from the McDonald guidelines. And this is just like reaffirming that whilst BMI is helpful up to a point, it doesn't tell us anything about body composition. So it's important that we go that extra mile to look a bit further. And we've got the Saltman and colleagues systematic review from a few years ago. So this is a helpful compilation of data in relation to CF and body composition. And there's lots of correlations. So we've got the correlation between increasing lean tissue and reducing disease severity. Also increasing lean tissue and increased respiratory health and bone health. But also increased fat mass and the correlation with reducing bone density, and also increased risk of insulin resistance with increased fat mass. And then just to add a little bit of data to this, so to make that our centre, a project that I presented on earlier this year in the European conference was entitled Framing Frailty in CF. And we've got a population group that are reassuringly living longer, which is amazing. But also we recognise that there's an increased risk of frailty with this. So 2 consultants and 2 physiotherapists screened 317 of our adult patients using the clinical frailty scale. And this ranks frailty risk from 1, which is very fit, through to 9, which is terminally ill. And of the 317 patients, 100 had body composition data available. And looking at the results, we can see on the pie chart on the left, the colour coding is in relation to the frailty score that was attributed to the individual, 6 being the most severe that was identified in the cohort. And this is defined as moderately frail, so requiring assistance with outdoor activities and assistance with some of the indoor activities, such as bathing or dressing. And we can see the percentage relating to each frailty score within the pie chart. So we had 2% of our population screened had frailty score 6. And then if we look at the correlation results on the right, we can see a very strong positive correlation between age and frailty, as we would expect or hope to see. Then if we're looking at the far right, we've got lung functions. We've got a very strong inverse correlation between lung function and frailty score. And if we're looking at BMI, although there's a correlation, it's a very weak inverse correlation between frailty score and BMI, whereas we found a very strong correlation between body composition, in this respect, fat-free mass index, and frailty score. So this suggests that, again, assessing body composition will help us and to provide a little bit more information beyond just BMI. And then thinking about additional themes. So again, this is focusing on bioelectrical impedance particularly. So it's accepted that prediction equations with these devices, they aren't designed for CF as yet. So they may over or underestimate absolute fat mass or fat-free mass. And both guidelines recommend that we consider raw data and use it whenever we can. So we're going to spend a few slides looking at the raw data and how we can actually apply it in the current clinical practice. But just again, whenever we're talking about this, it's probably worth thinking about how we relate such body composition data back to our patients in the real world. So this was a question that we asked from our survey. Which results do you feed back to your patient? Again, you can see that there's a splattering of data being referred back to our patients. There's no one single winner. Mostly revolving on the two-compartment model. We got some outliers there with the visceral adipose tissue. This is could well have been waist circumference, or we had one centre who actually did have access to DEXA, so it could have been the DEXA data as well. So when we're talking to our patients about relaying data back to them, it's absolutely paramount that we get their consent. So we have some patients in our centre who are more than happy to have assessment, and by far the majority of patients are more than happy to have their body composition assessment. Not everybody wants to hear the results, so it's always worth having that conversation with your patient. And it's difficult to feed raw data back to your patient because this is defined as the reactance, the resistance, and the phase angle from the machine at 50 kilohertz. And be wary if we're using the devices with our patients to show them the various charts and graphs, just because they can be very busy images. So there's just an example here on the right. This is a vector analysis plot, which we'll talk about in a second. But they can be busy, and they can have some scary words on there, such as cachexia and obesity. And what we do in our service is we just keep it simple. We talk about the two-compartment model. So we have our concept definitions when we're explaining these. So fat-free mass would be simply everything in an individual's body that isn't fat, so all of bones, all of the water, and all of your muscle. And then hand grip strength as well when we're using this. And it's really important that we personalize the information to the patient. We want them to stay engaged with this assessment option that we have. So I always go into the room pre-armed with the previous data, so that guaranteed they're going to ask me, how does this compare against the last time? So we can talk together about the trend over time. And I'll just focus on one thing. If all they want to hear about is their lean tissue or their fat mass, that's all I'm going to talk about with them. And if they don't want to hear any of it, then I won't. So again, just a little bit about the fundamentals. So the McDonald's guidelines encourage us to use multi-frequency bioelectrical impedance. And the reason for this is, so we have different models of bioelectrical impedance. So we've got this single frequency. What they do is they use a low frequency current defined with the green triangles on this image here. And they don't have a lot of current strength, so they're unable to penetrate the cell membrane. So they'll only be able to assess extracellular water, which means there's lots of assumptions made with this type of machine. Whereas the multi-frequency device will use low frequency and high frequency, highlighted by the red triangles here. So you're assessing total body water and extracellular water. Then the machine will subtract the extracellular from the total to provide intracellular. So they're much more sensitive to fluid shift and abnormal fluid status. So I mentioned right at the start of this section, it's important that we consider the raw data. And this is the reactance, resistance, and phase angle if you're using BIA. So this is data that will be routinely provided by the machine. And you need to be looking at it for the 50 kilohertz cycle. And I work in an adult service, so we can't directly use it, or we don't directly use it at the moment, but we do record it every single time because we're hoping eventually that we'll have an equation for adult people with CF. What we can then do is just retrospectively adjust all of the data we've got for many years, and then we can maintain that trend over time for the individual. But there is an equation available for younger people with CF by the Tratsiand authors back in 2016. And here's an example of it. So this is the equation from the article. Just out of curiosity, does anybody use this in their practice now? Any hands? No? Working with younger people. So it's a fairly straightforward equation. I'm not great at maths, but this is a fairly straightforward equation. And it's an equation that's one size fits all. So when they statistically analysed this, they found that age, gender, and even bioelectrical impedance device didn't have an effect on the outcome data. They used more than one BIA device in this. And I've highlighted in yellow where the raw data would fit into it. So we've got resistance and reactance are the only two bits of data used in this. And I thought what we could do is do an example. So David is a real patient in our service who had just transitioned to us. And we can see the raw data, resistance 498 ohms, reactance 52.2 ohms, and I've put the phase angle here as well. So initially what we need to do is just calculate the resistance index, which is just height squared in centimeters divided by resistance. You drop that into the equation, and ultimately you just calculate fat-free mass, adjusting for CF. Once you've got fat-free mass, you just deduct that from total body weight, and you've got fat mass then. And then you can calculate the index of both fat-free mass and fat mass. And you've got that two-compartment model, which has been adjusted for CF. And then what do we do with that data then once we've adjusted for CF? Well, again, the McDonald guidelines point us towards population reference data. So this isn't CF population database, but it is population database for younger people. The MOMO study we have, which focuses on the younger people, there's over 3,500 individuals, and they provide two-compartment model growth charts. And then we've got the Matelo study, which focuses exclusively on phase angles. There's many variables feed into phase angles, and we probably don't have time. I talked about this a couple of years ago. There's probably not. Catch up with me afterwards if you want to hear about phase angles. Get bored by it. But they've got a huge database of over 250,000 individuals. And then just using David's results that we just calculated here, this is using the MOMO study growth centile plot charts that they provide. So we can see with fat-free mass index and fat mass index, so David's falling just below the 50th centile. And then for phase angle, he's falling just below the 25th centile. And again, what we've done is we've accounted for CF. And then again, another tool that can be helpful when we're using the raw data is the vector analysis plots. So these they're independent of equations because they rely purely on the resistance, the reactance, and the phase angle. The resistance is the horizontal axis, the reactance is the vertical axis, and then the red line that I've drawn in there with the yellow dot, that's example of an individual. I've just plotted it anyway, but the arc of the tangent down to the horizontal axis, that's actually your phase angle. So what it's doing is it's overlapping each element of raw data on top of each other to provide almost like a 3D image of that data. So they're helpful for trend over time because every time you assess an individual and then you upload it to the software, then it'll map this on the same vector analysis chart. So they provide a nice, helpful, detailed insight into hydration status and cell mass. We can see very briefly, we've got the long axis, the north to south. This is in relation to fluid status. And then we've got the west to east axis, the short axis. This is in relation to cellular mass. So we can plot an individual's progress over time, again, using the raw data. And then another theme from the guidelines that crops up across the various guidelines in relation to the importance of tracking trend over time. And this is included, so the European guidelines identify hand grip strength, the importance of trend over time with this as well, for age 6 and above. And again, the guidelines are encouraging us to look at two-compartment model. But with these two tools, there's few studies that have assessed test-retest reliability. So if we're looking at something, the results of something trend over time, what we need to do is really, really try and make sure that we have optimal test-retest reliability. But there's very few studies out there that have looked at this. And it depends on really robust standard operating procedures. And this was a question that we asked in the survey. Surprisingly, it's probably the answer that surprised me the most, but of the 36 centres that responded, only 6 centres actually use standard operating procedures. So this suggested that we have a lot of work to do in order to normalise and to improve the reliability of these devices when we're using them. This was a study that we did in our centre. I was really interested a few years ago to find out what our test-retest reliability was like using these devices. So we looked at 89 adult patients with their consent at 2 time points, pretty much, well, always annual reviews, 12 months apart. And what we found assessing the various data, lung function, fat-free mass, hand grip strength, and BMI, that there was no statistically significant change across the time points. And taking all the values together, they were significantly similar at a p-value of less than 0.001. And just trying to, I work with images in my head. So trying to put this into a picture, I've got this bullseye target, and definition of these would be, so the bottom left is a tool that is both valid and reliable. Top right is a tool that is reliable but not valid because we're missing the bull. The top right is a tool that is valid but not reliable because we're hitting a different point every time. And the bottom right is a tool that is neither valid nor reliable. So using this data, we could see that we were probably getting test-retest reliability. We couldn't be sure of validity because we weren't testing for that, but we could rule out the other 2 bullseyes because we were thinking we were getting reliability here. So just as a final question we asked in our survey, what resources do you need? So there was a general themes, and there's no shocks here. There was a lot of information needed, a lot of education wanted, and guidance around competencies. So there was a demand for practice consensus, what to look for when measuring body composition, competencies for bioelectrical impedance users, training on how to use the equipment, a how-to guide, guidance on what methods to use and how often to use them, how to interpret measurements, information for my patient, and standard operating procedures. So we've been working on this within our working group for the last 18 months or so. We put a really successful workshop on last year to the point where we're doing another one hopefully soon. And this is a hands-on session for a full day, getting the option to use lots of different tools to assess body composition. And we're currently working on information for our patients, so educational tools for those. So just summing up, there's lots of tools out there to assess body composition. It seems like, at least in the UK, the genie's out the bottle, and that the most accessible tools are becoming the most commonly used. There's a lot of work to do around standardizing protocols and resources so that we can have more confidence in these tools. And also in relation to, there's still that missing piece of the puzzle, an equation for adult people with CF. And just as a side thought, that having read a little bit about strong CF, it seems like that's the perfect recipe to develop an adult equation. You've got 50 adult patients being assessed through bioelectrical impedance and DEXA, which is the basic ingredients that the Chirazzi authors use. But that's as much as I know about that. And that's it. Any questions?
So I have a question to start. Do you use frailty scores in your transplant evaluations?
We don't know. So this was a one-off study that we've done some frailty work a few years ago. We used 2-compartment model body composition, hand grip strength, and some physical tests as well. But these are standalone projects that we've used. But I think it's something going forward that every adult team is going to have to consider. Because there's definitely, we can see that just anecdotally within our adult service, we can see that people are becoming frailer at a much younger age.
Hi, Jessica Alvarez. That was wonderful. Thank you for presenting. I'm one of the investigators for Strong CF, and I will tell you that we are collecting the raw data for the exact reason that you were saying.
Great, thank you. Is there the potential to do the equation as well?
Oh, there's definitely potential to do the equations.
That's
extremely exciting. Thanks for coming back, David. It's great to see the progress you guys are making over there in the UK. I had a question. One is, how often are you guys checking BIA in your patients? Is it annually?
We routinely offer it annually at annual review, but we've got a fair number of patients who are keen to do it more frequently than that because they're following a training program, whatever they want to do, or if they're adjusting a diet. So I wouldn't want to do it probably more than every 3 months, just from a resource point of view, and then just time. And then also, you're probably not going to see a dramatic change in that time frame. So we would do it more than once a year, but at a basic level, we would offer it once a year.
Okay.
And I would say we probably did a study that was published last year looking at the change before and after Kaftrio. And just off the top of my head, I think we had, in that time frame, we had the majority of patients who are accepting just to have body composition assessed. So there's very few people decline.
Are you guys, is your center developing an intervention to increase lean mass? Are you working with the physiotherapist?
So going right back to when I first started in the adult team, the first project that I presented at the European conference was about exploring hidden depleted fat-free mass, and that was sort of like the start of us working much closer with our physiotherapy team. So hidden depleted fat-free mass, if you've got normal BMI but low lean tissue, if you're not assessing body composition, you're probably never going to spot these people, but they're at great risk. So this helped us to start that ball rolling so that we could identify those patients. And we're still looking out for those patients, but just routine care now when we're assessing body composition. And also anybody who has a trend that's heading down, that allows us to prompt that discussion with the patients, but also with our physio team and our exercise team, in order to think about adjustments that might change the situation.
Thank you.
Thanks, everyone. Have a good conference.
Our next speaker is Dr. Christopher Velez, who's an assistant in medicine at Massachusetts General Hospital and is the assistant program director of the Advanced Fellowship in Functional and Gastrointestinal Motility Disorders at Massachusetts General Hospital, GI. He's established GI clinical programs at the MGH Chelsea Health Center and the MGH Adult CF Center. I get to work with him all the time. His clinical expertise are disorders of the gut-brain interaction, especially esophageal disorders in particular, CF-related GI disorders, multidisciplinary partnership with foregut surgeons via the MGH Swallowing, Heartburn, and Esophageal Disorders Center. He has ongoing research activity about patient perspectives of management of disorders of gut-brain interaction, characterizing GI sensory neurodysfunction in CF-related diabetes, digestive health, disease burden in the LGBTQIA+ populations, and social determinants of health associated with quality of life or symptom severity, and finally also in GI education interventions to improve attitudes towards LGBTQIA+ patients. Without further ado,
Thank you very much for the kind introduction. So I have a lot to talk about over a very short period of time. I'll do the best that I can. So if it looks like I'm not giving a lot of topics their due justice, it's because I have to do so in the interest of time. Feel free to reach out to me after if you have any further clarifications for anything I talk about. So today I have a talk entitled Updates in Bowel Disease Management, Constipation, and C. difficile in People with CF. These are my relevant disclosures. Particularly, I would like to mention my disclosure with Arlic, since I'll be referencing an investigator-sponsored trial that I'm initiating with this company related to people with CF-related constipation. And importantly, a lot of the medications that I will be using are technically off-label because they not have been studied in people with cystic fibrosis, but in general, expert opinion would suggest that they can be used rationally in people with CF who have these complaints. So I will spend most of the talk talking about CF-related constipation, in particular updates over the past 10 to 15 years that some of you may not be familiar with in terms of constipation management. I will also discuss updates that exist in C. difficile associated diarrhea management as well, pressing issue with a lot of the patients we take care of, keeping in mind the number of antibiotics that they're exposed to. So a lot of what I'm discussing today is part of a wonderful series that was done in the journal Cystic Fibrosis, looking at best practices in the management of GI manifestations. So right now, I'm wondering if there will be an update to it because we are approaching some time from it, but it really is the best compendium of resources and guidance on how we manage CF-related gastrointestinal disorders, particularly from the GI perspective. So I'll start off with a case of a patient with CF who has constipation. 54-year-old woman presents with a complaint of bloating and decreased bowel movement frequency, worsened over the past 2 months. She had a prior history of pancreatic insufficient cystic fibrosis, extensive pelvic surgery history in part due to an endometrial adenocarcinoma, and she developed adhesion secondary to that surgery, resulting in a small bowel obstruction as well, managed conservatively. She relates that she had no GI symptoms generally whatsoever outside of this small bowel obstruction episode until she started ETI therapy for her CF. Consisting of elexacaftor, tezacaftor, and ivacaftor. So the symptoms that she's having and that she is expressing at this initial consultation are generally more indolent than her SBO episodes, but generally fairly similar. And she has been on routine, generally over-the-counter laxatives, not really improving her symptoms. She had a PEG go lightly clean out and still felt bloated even after she had had a large bowel movement, and starting an osmotic laxative in the form of PEG, i.e. Miralax, and she was started on linaclotide. The addition of linaclotide improved symptoms initially, but no longer so. She was switched to prucalopride. I'll go over what these newer medications are. Some of you may not be familiar with them if you're not in the GI space. Had some improvement, but generally is just tired of feeling crummy from the gut perspective, particularly since it seems everything started at the initiation of ETI. So she wants to know, I live my life whenever I have my abdominal pain, wondering, am I going to have to go to the hospital because is it a small bowel obstruction? This all started after I started ETI. Should I stop it? My lungs were doing relatively well. Why would I take a medication that I feel is making my gut unhappier? And she's a normally active person, gardens, takes care of her grandchildren. She wants to know, will she get better? So a lot of what I spend in my non-CF hat is focusing on neurogastroenterology and motility disorders. And I'll have to say that we tend to put all constipation in one bucket, but really there are two types of constipation that exist. One, and I use the analogy with my patients and with my trainees, of a tube of toothpaste. So the type of constipation that we tend to think of, including in people with CF, but even in people without CF, is the slow transit constipation. And the analogy I draw with patients is imagining as if you're not squeezing the tube of toothpaste tight enough. The second type of constipation that I think gastroenterologists and non-gastroenterologists do a horrible job about considering, particularly in female patients, are the pelvic outlet obstruction types of constipation. So these are disorders of the anal rectum, of the muscles of the pelvic floor, of the pelvic floor that can cause constipation. And that's as if the tube of toothpaste, the cap is on too tight. So it doesn't matter if you are squeezing that tube of toothpaste tight enough. If the cap is on too tight, it's not going to come out. So a lot of people who get labeled as having refractory constipation really are people that probably have a pelvic outlet obstruction and probably should undergo anorectal manometry testing. And it could be that with biofeedback or basically physical therapy to reteach yourself how to poop, you would have more of an effective response when it comes to constipation management. And what I like being as a humble gastroenterologist compared to my much smarter pulmonary colleagues is that really GI disorders come in three flavors. So one flavor are the organ structural disorders. The other flavor is motility. And the last are what we used to call functional GI disorders, but our field has moved to calling disorders of gut-brain interaction, in part because functional doesn't mean anything. And functional has been used in the past to address people who are thought to have more psychosomatic spectrum complaints. And nothing makes a patient feel more frustrated than being told that they're crazy as an explanation for their chronic GI symptoms. So why do I mention this degree of discussion for constipation in a CF-related talk? In part is because I think that there are people that probably have some elements of organ structural disease, people who have had meconium ileus surgery, people who have had bowel obstruction surgery. There are reasons why people with CF may have slow transit and motility disturbances because of the viscosity of bowel contents, because of the way that we tell patients with CF to avoid. Historically, it has been stated to people with CF that they should avoid high fiber diets and things like that. These are all things that impact motility. And I think there may be even a cohort of people with CF-related constipation that maybe have IBS spectrum complaints, but we don't technically give them that diagnosis because we used to historically state that IBS was the disease of exclusion. We no longer state that anymore. We state it in a positive framework, saying that we've completed testing. Your testing shows you have IBS. A patient hears that very differently than, I don't know, we haven't found anything, it's probably IBS. One causes anxiety, the other sort of gives you a sense of resolution. So CF-related constipation and distal intestinal obstruction syndrome deserves special mention. We think about in the GI space that constipation begets DIOS, DIOS begets constipation. So you really need to make sure that a person is on a good regimen and having adequate bowel movements to try to prevent those episodes of distal intestinal obstruction syndrome in the past, or in the future rather. So this is a very busy slide, and I'm not really asking you to read every single bit of text, but what I would want to emphasize is that I think a lot of the people in this room who are not GI focused really think that constipation management in the 2020s stops here. Fiber, Miralax, PEG, Bisacodyl, Stenocides. And a lot of you may not be aware that there is entirely new categories of constipation treatments that now exist that have been approved since the 2010s. So the downside is with our people with CF population is that a lot of those older, newer agents, thinking about linaclotide, lubiprostone, and plecanatide, either directly or indirectly act via CFTR. So it ends up, and I would argue that I haven't gone through study by study, but I would imagine that people with cystic fibrosis would generally have been excluded from these studies. So we're left with a newer class of medications that we don't know how well they work or don't work in people with CF. There is also these lubiprostone, plecanatide, and linaclotide basically change ion ships in order to attract more water into the gastrointestinal lumen. That's how they work. Prucalopride, and the brand name for lubiprostone is Amitiza. For linaclotide, it's Linzess. For plecanatide, it's Trulance. Prucalopride is a serotonergic agent that basically stimulates colon contractions. So the brand name for prucalopride is Motegrity. In Europe, they're also using prucalopride to treat gastroparesis. In the US, the indication for prucalopride exists solely for constipation management. But as I've mentioned, great, I said, newer medications are available that perhaps we're not using enough in the community of clinicians caring for people with CF-related constipation, but a lot of them work with via CFTR. What I will say is, in my mind, the way I would go about that dilemma is by stating if someone's on a modulator, that means by definition they have some CFTR activity reconstituted. These would be the people I would think about asking your gastroenterology colleagues, have you thought about recommending linaclotide? Have you thought about recommending lubiprostone, plecanatide? Have you thought about a stimulant laxative in the form of prucalopride? What you can imagine is if there were a new work class that were available that completely bypassed the CFTR channel, would that be a potentially attractive agent to consider? And that agent, I would argue, is tenapanor. Made by the company Ardelyx, which I mentioned in my disclosure slide. So tenapanor is a newer agent that acts as a transporter that brings more water into the GI tract, that is through a mechanism that does not directly or indirectly look at that interact with CFTR. So I have a QR code here because the reason why I've listed Ardelyx as a disclosure is that I am in the process of finalizing an investigator-sponsored trial with Ardelyx. We're going to be looking at use of tenapanor and getting an IND from the FDA for an expanded indication for tenapanor. And we're going to be recruiting 20 patients around the country who will be able to, assuming if any of you would be interested in giving this information to your patients, we're interested in recruiting for a nationwide cohort of 20 people. This link will go into a Google form that will go into our research core. And then once the study is live, we can reach out to see if you would be willing to share the study with any of your colleagues. So we're hoping that this will be a first step among many steps in studying the use of these newer constipation medications in people with CF. So I was asked to talk about a newer technology which is immediately attractive, the vibrating colon capsule. I have been told that people who take it don't feel it, but I can't imagine that is to be the case. But basically, from those of you who have taken care of people with CF who have constipation, it's a bothersome nuisance complaint. It lands people in the hospital. We're trying to find any way to try to reduce the burden of CF-related constipation in people with CF. And as the name suggests, basically you consume a capsule that vibrates. It kind of shimmies itself through your colon and gets the stool moving. And it looks like, based on research that's been published, that you do have an increase in complete spontaneous bowel movements when you compare it to placebo when it comes to use of the vibrating capsule. The caution I would have in people with CF is that, one, it hasn't been studied in people with CF. And two, there is the theoretical risk that the capsule could become lodged in the GI tract, particularly, let's say, in people who have a history of meconium ileus surgery at birth, and maybe not the best thing I would want to reach out to. But if, let's say, you have a motivated patient who wants a mechanical way to treat their constipation, who does not want to take a medication that's going to be impacting at the cellular level in the GI tract, maybe getting a patency capsule, which is a way in GI that we basically ask people to swallow a barium capsule that's large enough to get stuck. You have them swallow it, then you shoot an abdominal X-ray to see if the capsule is passed or not. Eventually, if the capsule does not pass, it will dissolve. That way, it's the dissolved capsule that doesn't pass versus the object that would need a surgical resection. Going back to that very, gastroenterologists really take care of three types of disease, there is a debate whether or not people with CF-related constipation can or cannot have IBS-C. From that best practices series in the Journal of Cystic Fibrosis, there was these series of statements relating to IBS-C. So IBS-C is thought to be, in people without CF, to be related by visceral hyperalgesia. Basically, you feel things you shouldn't be feeling. Your GI tract isn't contracting more, isn't more full of stool, but those pain threshold pathways are not appropriately calibrated. So they're sending pain panic signals, even though things are moving along normally. And while people with CF may not be able to meet the strictest definitions of functional gastrointestinal disorders because there is something structural to explain their symptoms, it could be that in the refractory state, where people are complaining about symptoms like the patient that I was just describing in this case, if you maybe got out of the it can't be IBS paradigm, if you think about it, well, what if we treat this patient like IBS? You may be able to get them to that quality of life that they're seeking. So these are the factors that are thought to influence the development of all disorders of gut-brain interaction, including DGBIs. Basically, there may be some early life factors, genetics, culture, environment. There are some thoughts that IBS may be mediated by this ion channelopathies, so that's something that should resonate in a CF audience. Then there's an interplay between these early life factors, trauma as well, infection, psychosocial factors, physiology between the gut and the brain and the gut. That's why we call it disorders of gut-brain interaction. And the spiel I give to patients usually is that there are more nerves in the gut than there are in the spine. Serotonin, which is acted upon by antidepressants, there's 10 times more serotonin in the gut than there is in the brain. We're just starting to understand this interplay between the first brain and what we call the enteric nervous system, the second brain. And in theory, you could completely remove the entire GI tract. If you remove the entire GI tract from someone and preserved their enteric nervous system and put it in a nutrient-rich saltwater bath, the GI tract can continue to function. Doesn't function well because it's losing those central nervous system inputs that tell it to stop secreting, stop contracting, but it could work without central nervous system input. So DGBIs impact the entire GI tract from the esophagus down to the anal rectum. So they have GERD spectrum complaints, bloating, abdominal pain, chronic constipation spectrum of complaints. And what I would say is, for those of you who are being told by your gastroenterology consultants, nothing else to do, they're pooping and they're still in pain, I would ask you to push them and to say, well, why can't we treat this like IBS? Maybe we should be thinking about cognitive behavioral therapies. Maybe we should be thinking about complementary alternative naturopathic regimens like ginger, turmeric, curcumin, acupuncture, tai chi, yoga, diaphragmatic breathing. These are all medication-free ways in which one can try to manage persistent symptoms versus sort of being told nothing more we can do, which unfortunately a lot of my colleagues in GI do. So case wrap up here. So she wasn't feeling good relief from Miralax plus linaclotide and Miralax plus prucalopride. So what we did was we actually kept the prucalopride on board because that was a pro-motility agent. We then added back the linaclotide because it has a different mechanism of action, bringing more fluid into the GI tract. And then we treated her like she had IBS. So we gave her a more peripheral acting central neuromodulator in the form of gabapentin. And we gave her a more central neuromodulator in the form of duloxetine Cymbalta. And that was able to achieve near total symptom resolution in this case. Now to C. diff. Opposite issue. So I would say what makes C. diff management challenging for a non-ID, non-GI crowd is that ID and GI they don't publish guidelines that are exactly the same. So I, as a gastroenterologist, have the cognitive bias of thinking that my society is probably right. But I want you, if you're noticing any difference that you've seen from ID recommendations, it could just be that the specialist perspective is different. And this is a guideline that was just recently updated a few years ago. So CF in the GI tract provokes multiple disturbances that likely contribute to dysbiosis, and part of that dysbiosis we think of as sort of a unhealthy community of microbiome and microbiota in people with CF that have been exposed to a lot of antibiotics. But it also probably changes the groundwork in which C. difficile can colonize and can cause C. difficile associated diarrhea in people with CF. So basically, I won't go into the basics of C. difficile management just because that's beyond the scope of the talk, but I think some of you will be familiar with metronidazole, using vancomycin, using fidaxomicin, and generally antimicrobial therapy is the first line when it comes to treating C. difficile associated diarrhea. And when either someone has a very fulminant C. difficile toxic case that requires an emergency colectomy, that is the most severe form of C. diff you can get, or if someone has failed antibiotics, then you start thinking about fecal transplant. So in my relatively short career of about 10 years, we went from you really had to know someone very well to ask them if they were willing to provide a little zhuzh for you. And you would be stuck in the endoscopy suite with a blender, with a cheesecloth, and making it yourself. Not the most appetizing. Fortunately, companies stepped in and now they recruit healthy donors who have a low body mass index, who don't have a history of infectious illness to provide samples. But what some new updates that exist are these live bariotherapeutic products, Rebiota and Vaust, which basically still take the same stool donor pool, but they refine the bacteria versus just giving a whole stool transplant. They give the most healthy or what are thought to be the most impactful organisms back to someone who has a history of C. difficile. The new recommendations and the new guidelines don't account, and that I just mentioned, don't account for these LBPs. But basically, it's a similar approach for both Rebiota and Vaust, where basically they take stool specimens from healthy donors. They ask you ideally should have no use of antimicrobial agents recently, and then you infuse it and you hope to prevent further C. difficile infection. In terms of clinical pearls, updates do exist in CF-related constipation management. Push your gastroenterologist to actually get with the times. I would generally favor using CFTR modulating secretagogues when someone is on CFTR modulator therapy. I think linaclotide is great. I think lubiprostone is great. I think plecanatide is great. But if someone is not taking a CFTR modulator, I wouldn't recommend those agents. And the vibrating capsule, we need more information, as well as the live biotherapeutic products in C. difficile diarrhea. Thank you.
Yes.
Hi, great talk. Adam Stein from Northwestern. I have three things. One, we did recently publish an update to that 2017 supplement in all journals, don't ask, but pediatric pulmonology. So it's available online. It just came out. Second thing, I love the toothpaste analogy. That really explains it well. I'm going to definitely use that. And then the third thing is, how do you dose linaclotide? What do you start with, and how high do you go?
So, keeping the caveat in mind that I am an adult gastroenterologist, what I do for my adult patients is I sort of do the Goldilocks method. I start off at 145 micrograms because it's available in once daily formulation, 290, 145, or 72. If they're not going enough, go up to 290. They're going too much, you go down to 72. So that's, and then they have to be on it for a month before we make any changes.
Got it. Thanks.
Hello, Jade, University of Rochester. I just had a question about the study for constipation. Do you happen to know any inclusion criteria yet? Like adults versus pediatric, and are we talking like pancreatic sufficient patients?
So likely would include pancreatic insufficient patients, would only include adults. We're at the negotiating stage to see what the inclusion exclusion would be.
Okay, thank you.
Hi, Eliana from University of Washington. I had a question about the C. diff. Have you had patients with C. diff, and how did they present clinically if you did?
Generally abdominal pain, fever, and frequent bowel movements are the cardinal symptoms of a C. difficile infection. There are people who are that are asymptomatically colonized, so you have to have protocols where you don't inappropriately treat someone who's colonized but not having a severe C. difficile bout.
Have you guys seen increased constipation and then diagnosed C. diff from that?
Increased constipation as a sign of C. diff? Mm-hmm. I haven't, but I also am not seeing the full breadth of C. difficile. Usually we have, because we're so hyper specialized in my division, there are like C. diff focused research clinicians who are seeing a lot of the C. diff cases. My sense is less likely, but it's hard to argue if one has had that experience.
Okay.
Yeah.
Probably come to ask you some questions afterwards. Thanks.
I'm glad your patient you presented got better with the therapies you gave them. If the patient still doesn't get better, what recommendations do you have for those refractory constipation patients beyond what you already have done? And I appreciate that you're going to do the tenapanor study.
Yeah. I define what they mean by not getting better, because if they're not getting better, so patients will say that, and then we take them at face value. I always trust my patients, but I tell them that we use vocabulary differently. So if they say I'm not getting better, why? Well, because I only move my bowels twice a week, and that third or fourth day I feel bad, I say, well, we can give you maybe a mega dose of Marilax, 7 capsules, 32 ounces, repeat in 12 hours. If you haven't had a bowel movement for 3 days. If it's more the pain component that they're moving their bowels every day, but they're having pain, then I may switch out neuromodulators. I may go from gabapentin to pregabalin. I may go from duloxetine to a tricyclic antidepressant. So that's, if it's pain versus bowel movement frequency, that's the way that I decide how to adjust management.
Great talk. Thank you. And just I will add a comment to the question about constipation and C. diff colitis. Mm-hmm. So a lot of hospitals, a lot of laboratories have guardrails that if the stools are harder, they will not even run a C. diff test. They will just cancel it. So because both doesn't coexist. And if that patient has C. diff, it's probably colonized. But sometimes, as I said, not all hospitals follow that. And then also often practically, as a clinician, what we do is, or the patient, what they may do is, like if they are getting a clean out, they may send a sample and then it may become positive. Mm-hmm. And then kind of we think it's C. diff colitis. And then also C. diff in CF patients, very interesting. They don't get C. diff colitis that often, something with the CFTR kind of like interacting with the toxins. But if they get very sick C. diff colitis.
Okay, thank you.
One last question.
Hi, my name is Gila Ginsberg. I'm a PEDS GI fellow from Children's Wisconsin. One of the mainstays of treatment for disorders of the brain-gut interaction, at least at our center, is the auricular neurostimulator device. And so I was wondering if you had any experience using that device in the cystic fibrosis patient population or aware of any ongoing research.
I have not. We do use a nerve stimulator device at the vagus nerve for functional dyspepsia, but that's in our research group, but not targeted for a CF-related indication, in part because, unfortunately, like a lot of GI studies, having CF counts as one of those severe systemic disorders that prevents you from being included in the study. So I think that is a gap in a lot of CFGI research.
Thank you.
Thank you.
And for those of you in back, there are a handful of seats up front. Anybody wants to sit down? And I get to introduce our next speaker. Amy McCluskey is a senior CF and respiratory dietitian at the Alfred Hospital in Melbourne. She's worked in both the UK and Australia as a CF dietitian. Her career started in respiratory, following which she specialized in diabetes. In more recent years, she's focused her practice in CF, working at the Northern Ireland CF Centre at the Belfast City as a CF specialist dietitian. In 2023, she relocated to Australia to join the respiratory team at the Alfred Hospital, which includes the CF, lung transplant, and general respiratory programs. Amy has a special interest in weight-neutral approaches, holistic CF care, and CFRD. Welcome, Amy.
Hi, I'd just like to thank the NACFC for having me to speak today on the international perspectives on the use of CGM in CF-related diabetes. I have no disclosures, and these are my objectives today. So, as most people in this room are familiar with CFRD, and it's a hot topic in CF right now, and it's the topic of the plenary session tomorrow, CFRD is a common complication of CF occurring in 20% of adolescents, 40 to 50% of adolescents in the US, and 30% of people with CF in the UK. Microvascular complications are now more common as a result of prolonged life expectancy of patients with CF, with increases in retinopathy, gastroparesis, and neuropathy. Survival is significantly impacted by the CFRD status, with 60% of people with CF with normal glucose tolerance living to the age of 30, compared to only 25% of those with CFRD. As you can see, there is an increasing incidence of CFRD as people with CF age, and as from this graph from the CF Foundation, and this can be seen in similar reports by the European Epidemiology Registry of CF and the UK CF Registry. Based on the CF Foundation 2023 data, people with CF are living longer, with the median age of survival for people born with CF from 2019 to 2023 being 61 years, a substantial jump from 2 decades ago when life expectancy was 38. So, in the post-modulator era, you should be looking out for dysglycemia associated with clinical decline, with studies showing the relationship between the development of CFRD and poor nutritional status and lung function, with a more rapid decline occurring in people with CF with impaired insulin secretion prior to diagnosis. Therefore, the detection of early glucose abnormalities enables us to distinguish people who are at risk of clinical decline. Body composition changes and increased BMI in a post-modulator era, with rates of overweight and obesity increasing worldwide. Insulin resistance may play a larger role in the CFRD pathogenesis. And then cardiovascular risk. We know that people with CF are at increased risk of adverse cardiac disease events. Improved control of CFRD will reduce the risk in other forms of diabetes. And with poor diet quality in CF, reliance on high in refined sugars and saturated fat meals will also play a huge role in CFRD treatment and moving away from the legacy diet. So in saying this, if you get your phones out and maybe try and scan to see how are you all screening for CFRD. Barcode should remain here. So So it seems like a lot of people continue to use OGTT, with some using HbA1c, and then OGTT, and a small amount using CGM. So in saying that, what we know from this room, how are we screening across the globe? In Australia, the Standards of Care 2023 recommend that an OGTT for patients aged 10 years or older is recommended during a period of clinical stability. In the UK, the Management of Cystic Fibrosis Diabetes 2022 recommends that everyone with CF should have annual screening for CF or D with an OGTT, and if it meets criteria for diabetes, this needs to be followed up with glucose monitoring with serial blood glucose measurements such as CGM. Similarly, here in the US, the CF Foundation recommends an oral glucose tolerance test from 10 years. So, buzzword at the moment in CF or D seems to be CGM, but what is it? CGM is a device that measures glucose in the interstitial fluid continuously and updates throughout a device that is attached to the body. And we know there is a good correlation between blood glucose and interstitial levels. And CGM has demonstrated to correlate with glucose measurements at OGTTs in CF. So what are the benefits of CGM in CF or D? We know it could enhance precision in screening. Early and effective treatment of CF or D is essential to avoid microvascular complications. And from the CF Registry 2019, we know that only 30% of adults eligible for screening took part. It can help with the early detection of glucose dysregulation, empower people with CF in the management of CF or D care, give us real-time glucose data, and help healthcare professionals personalize intervention to each patient, and help increase patient satisfaction by decreasing burden of care. So CGM can be used daily or intermittently for a wide variety of disease processes. I've highlighted where CF or D fits into the daily use of CGM for treatment purposes, and also where we have opportunity to potentially use CGM in impaired glucose tolerance. CGM holds potential as a behavior modification tool with added benefits of personalizing dietary management and ensuring safety during exercise in adults with CF or D. Now, if you could get your phones out again, apologies. So how is everybody in this room using CGM in the treatment of CF or D? Apologies, I might have to change the questions. Okay, great to see that such a large amount of using CGM, with around 60% using it and intermittently with 19%. So with that, I would like to talk about CGM in the UK. I wanted to talk about broad guidelines for CGM use in the UK and how this affects our care model. As from the NICE guidelines update in 2022 on CGM and type 1, it states that some people have insulin insufficiency because of other conditions, and the committee noted that these people would get the same care as people with type 1 diabetes. So they should have access to CGM in the same way, where CF or D should fill into this. And also that there are no prescription charges for people living in Scotland, Northern Ireland, and in Wales, and with people in England being exempt for prescription charges for CF or D. The standards of care recommend joint management with endocrinologist experience in CF or D along with a CF dietitian. So next of all, I'd like to talk about the model of care at my previous centre in Northern Ireland. The term model of care describes how care is provided to a group of people with clinical condition at an individual, service and system level. This is a specific example of how CGM can be incorporated into the CF or D care model at a service level in the UK, in Northern Ireland. The model had 4 components, with a CF/D MDT clinic, which was run monthly, included a dietitian, an endocrinologist, and a diabetes nurse, who is also a CF nurse, and a mixture of telehealth and in-person. It also had group education classes on diagnosis. Patients were offered group educated classes on CF/D with the dietitian and the diabetes nurse, and this could be done in group or in a one-on-one session. There was psychology input, and also the dietitians are offering a weekly clinic for one-on-one dietetic education with a review of diet records and CGM logs. Next, I wanted to discuss CGM in Australia, where I am at the moment. Unfortunately, CGM is not funded for patients with CF/D over the age of 21. It is available for all type 1s, available for people with CF/D that are less than 21. There is some on study access, self-funded, and some are getting compassionate access on a case by case. And there is ongoing efforts and advocacy by the Cystic Fibrosis Australia for subsidised CGM. There is not a national system level for model of care for the use of CGM in CF/D in Australia, and there is a spectrum of how CF services operate throughout the country regarding CGM in CF/D. At the Alfred in Melbourne, we are currently screening with OGTTs for people with HbA1cs greater than 5.5. They're referred to a specialist diabetes consultant and seen separately in the CF clinic by the dietitian and psych and social workers. In other CF centres in Australia, similarly to the US, the endocrinologist will join the CF MDT clinic at certain intervals, with some nurses and dietitians being specialist credentialed in diabetes. I just wanted to highlight ongoing advocacies in Australia with this recent qualitative study on models of care with CF/D and CGM conducted a survey of patients in focus groups with healthcare professionals with the aim of co-developing an ideal model of care and evaluate the acceptability of CGM, with the ideal model of CF care being a due specialty co-led service with an endocrinologist, diabetes educator, CF dietitian, and respiratory physician. So with that, I wanted to speak more about the evolving role of the dietitian to CGM and incorporating this into our CF care model globally. We know that people with CF have a higher intake of sugar, refined carbs, and a low intake of whole grain and dietary fiber. And a revision of dietary guidelines and practice change in CF nutritional therapy is warranted to optimize nutrition and health outcomes. We need to support for behavioral change and provide support and strategies for making substantial dietary changes and addressing any barriers to adherence. And CGM can help us by allowing a patient view on how their lifestyle affects blood glucose levels and reinforces the education we give. We will, as always, provide education. However, CGM and diet and food diaries can identify specific foods or activities such as stress, illness, medication adherence, and how these affect individuals' glycemic control. This approach can then empower individuals with CF/D to tailor their treatment according to their lifestyle and can help reinforce education given. And an example of this is a patient I had only this month. This is just their 1 day of CGM and one of their diet histories. And they were recently diagnosed with CF/D and had self-funded a CGM. And they were shocked to find out how some of the foods affected their blood glucose levels. As we can see, the patient had a very sporadic meal pattern, had snacks high in free sugars, had sugary drinks, had large portions of high GI foods. And the patient was really shocked about how his food choices had affected his blood sugar levels. And with this, it gave me the opportunity to provide education on glycemic index, showing how different carbohydrates based on their glycemic index affected their blood sugar levels, discussing portion sizes, decreasing portion size of carbohydrates and increasing portion sizes of protein and veg, and overall looking at diet quality. And also for this, for newly diagnosed CF or D, CGM can also be helped to make someone understand and gain acceptance for the need for insulin and provide a layer of reassurance about hypoglycemia and how to improve quality through reduction of added sugars and refined carbohydrates. Another thing we can be doing is providing group education sessions. Given increased demand for nutrition input in CF or D, the hybrid blend of telehealth and in-person clinic structures, group education sessions may be an effective way to increase dietitian contact and provide nutrition education and counselling, and even create a community among people with CF or D. These can be developed similarly in the likes of Desmond or Daphne and Bertie for type 1 and type 2. We can also look at the extended scope of practice for dietitians. I think we need to think about how dietitians can extend their scope and help support people with CF or D. In the UK, in 2016, dietitians were granted supplementary rights for prescribing, and they are suitably qualified to help people find the balance with diet, lifestyle, titration of insulin and other medications by deep prescribing, titrating, or regular adjustments to help improve blood glucose concentrations. Similarly, in Australia, dietitians can become credentialed diabetes educations, and they can help monitor, manage and blood glucose levels, educate on the use of medication, including insulin therapy, and in some states are able to adjust insulin. So in saying this, what are the future directions for CGM and CF or D? We need updated dietary guidelines for CF or D, and more research into CF-related diabetes is needed and could be facilitated with CGM to inform guidelines on optimal management of CF or D. Large long-term prospective studies are needed to determine which CGM measures or cut points predict clinical deterioration in CF and the risk of developing CF or D. Large-scale screening studies across various clinical phenotypes are necessary to determine which CGM measures and cutoff measures that can be reliably differentiate between patients with or without CF or D. With CGM can also come anxiety. So balancing potential anxiety associated with CGM and quality of life is needed. Further international advocacy and public policy efforts are needed to improve access to CGM across the globe, an extended scope of practice for dietitian and potential allied health-led CF or D clinics. So in conclusion, CGM can empower patients to improve diet quality and glycemic control. Dietitians play a critical role in the MDT in managing diabetes through the use of CGM. And more research is needed to elicit targets for CGM interpretation in people with CF who have dysglycemia. And improve access to CGM is crucial for equitable care in CF-related diabetes. I'd just like to acknowledge my former colleagues in the Belfast City Hospital who have helped me with this presentation. Also, the diabetes dietitian and endocrinologist in Queensland, and of course to my CF team and especially my manager, Juliana Bailey. Thank you. Questions? Anybody has any questions?
Hi, I'm Catherine Cutney from Cleveland, Ohio. My question is more practical. So if in the UK there isn't like a clear cutoff to say this is a normal CGM screen, this is an abnormal CGM screen, how does that work? Like, how is it determined when it gets escalated? Does an endo always have to look at it? Are the nutritionists interpreting them? Like, how do you interpret it if there's no cutoff?
As in for diagnosis?
Yes.
We usually OGTT would be used first and follow up with CGM before
I see.
insulin is
So they're
prescribed.
not just doing CGM for
No.
screening in the UK. Okay, thanks for clarifying.
When you have patients whose diet is, I call it they're having Cheetos for breakfast and drinking a lot of Mountain Dew all day kind of foods, how do you have them cover it with more insulin, or do you tend to try to talk them into changing what they're eating?
I think that depends on the patient. You have to gauge how they feel and what their ability to make changes is to use that behavioral change. And it's maybe yourself and the endocrinologist and the patient coming to a conclusion. You'll always have some patients that aren't going to change their diet. And for that, you might have to decide about increasing insulin, but you also have to warn them about the other risks associated with that. So ideally, change the diet and then look to insulin, but you really have to gauge the motivation of your patient first and their barriers to making changes.
Hi, I just have a question for patients if they are being monitored for glycemic changes with a CGM. Are you asking them to consume a slightly different diet or do any kind of a fasting with a high sugar intake to see if they have excursions outside their normal diet?
No, they should continue with their normal diet. And I think that's where maybe we find OGTT can differ in that sort of indeterminate glucose tolerance, because, you know, most people, when you're doing an OGTT, aren't having that large amounts of carbohydrate all at once. So I think CGM is a good way of showing us what day by day basis their blood sugars are doing. So you'll be keeping them to their normal diet.
And are you excluding any patients who are acutely ill or coming off of any exacerbations by any time period at all?
Yeah, usually just your normal. Maybe I've no exact amount of time, but usually it'd be 2 to 3 months after any exacerbations, and making sure their CRP's normal and all their inflammation markers are normal.
2 to 3 months after the onset of initial symptoms or the end of antibiotic treatment? Or
The end of antibiotic treatment.
Thank you.
Hello, Henry Salada, endocrinologist at UCLA, Los Angeles. So mostly a comment about the OGTT test. So we need to understand that the OGTT was created mainly to study patients for type 2 diabetes. And then we're using as a gold standard for patients with CFRD, which it may change within the next weeks, but also that there are already some papers that has published CGM parameters for screening and diagnosing CFRD. So actually I'm using in my practice those parameters. There are small studies, of course, but mainly when you see postprandial hyperglycemia and having like, I think it is more than 14%, more than 140 milligrams per deciliter, and more than 8% of the time, more than 180 milligrams per deciliter, that, you know, give us like, the study shows like a lot of high sensitivity and specificity to diagnose CFRD and screening CFRD. So knowing of all the complications that we have with OGTT tests, with hypoglycemia of the OGTT test, and this is not a very, you know, friendly test. Mainly at UCLA, we're not using much OGTT test. I tend to go with CGM for screening. Sometimes we're dealing with insurance issues, but I think that CGM, I'm pretty confident that could be used like as a tool for screening and diagnosis very soon.
Yeah, I 100% agree with that. I think that's the way everything's going. Apologies, I only know the millimoles per litre, not the milligrams per deciliter, but we did have cutoff points in the UK also.
Yeah, I was just going to say that is what we use in the UK. We use the parameters he was discussing, and we use a lot more CGM, particularly if they've already been diagnosed with impaired glucose tolerance. It's much more useful.
Yes. Thank you.
Thank you.
Thank you.
All right, our last speaker is Maria Santini. She is a clinical nutrition supervisor at Hasbro Children's and Emma Pendleton Bradley Hospitals in Providence, Rhode Island. In addition, she's a pediatric nutrition provider for both celiac and pediatric cystic fibrosis at Hasbro. Maria earned her Bachelor of Science in Nutritional Sciences degree from McGill University in Montreal, Canada. In 2013, she helped to oversee the EPIC nutrition build, training, and implementation across a 5-hospital system, and continues to support system enhancements related to workflow, documentation updates, and order set evaluation for patient safety. Welcome, Maria.
Really short, so I'm going to move this down a little bit. Thank you so much for that introduction. And if you've ever wondered why a dietitian might be so interested in the topic of informatics, you are about to find out. My name is Maria, as Sarah mentioned, and I've been involved in some capacity with nutrition informatics for probably about 20 years, which seems like an eternity, but it is what it is. So my role now is not only to work with patients, but I help to maintain nutrition documentation standards and workflow optimization across 5 different hospitals. And so my goal today is that besides trying to make this the best 20 minutes of your life, my goal is to help you learn how to use technology that is going to support efficiencies in your work. Hopefully this is going to work. There we go. So I don't have any disclosures to make today, but for the purposes of this talk, I will be referencing several electronic health record products to illustrate their capabilities, but certainly does not represent any commercial bias. Our main objectives today are really to define what nutrition informatics actually is, be familiar with essential data elements that are used to structure our documentation templates, and review tools to optimize our workflows and optimize productivity. So before delving into this product, like any great dietitian, it was important to learn what everybody wanted to know about nutrition informatics anyway. So we created, you guessed it, a survey and sent it out to the listserv to gather some preliminary information. And what we asked was, what electronic health record or EHR are you currently using? Are you transitioning to a new EHR? And what would you like to learn more about as it pertains to nutrition informatics? Here are our responses. Thank you to the 23 people who did respond to this little survey. And as it turns out, no big surprise, but about 70% of people are currently using Epic. And then there's a mix of Cerner, Sorian, Sunrise, with a few who are currently in transition to Epic. Now, while Epic may be the most ubiquitous EHR in the US hospital industry, that doesn't mean that all large health systems use it. In fact, of the top 25 largest health systems by revenue, 15 are exclusively using Epic, 3 are switching to Epic, and 7 others are using some combination of either Cerner, Meditech, or Epic, which I would say, given those numbers, that's pretty similar to what our survey respondents were doing. So while we are going to be reviewing a lot of the Epic EHR tools today, I think it's important to remember that even if you're not using Epic, there are a lot of data elements that are important to be familiar with so that you know how to incorporate some of these strategies into your daily work. So in terms of what RDs really wanted to know about in terms of nutrition informatics, broadly, what is it? I don't even know what this is. Are you talking about AI? I'm not sure. And also to be supported in switching to Epic and learning more about various documentation tools, enhancing productivity, running reports, doing research. All of those things are topics that people wanted to learn more about, and we're going to touch base on those. So if you didn't already know this, the Academy of Nutrition and Dietetics has their own Nutrition Informatics Dietetics Practice Group. Of course, I'm a member, right? But they produce lots of great educational materials, and one of the infographics they produced was to try to relate to people what nutrition informatics is, and it really is the intersection of nutrition, information, and technology. Informatics is actually the study of how to design, develop, and use information technology to store, process, and present data. So informatics is often referred to as the science of information. But what does it mean in a practical way? Like, that's all great information, Maria, but I want to know how this is going to help me. And what the bottom line is how we use technology to interpret, synthesize, and summarize data for our colleagues colleagues and enabling us to do research, that's what nutrition informatics does. Besides helping us to write orders and documenting and communicating complex care plans and so forth. So how does nutrition informatics distinguish itself from artificial intelligence or AI? Well, we all have heard lots about AI lately, and actually the AI algorithms, as you know, require very large amounts of data to learn, generate models, and make accurate predictions. What informatics does is it provides the framework to manage this data effectively. So to organize data for AI models to share and transmit this information not only within an organization, but external to an organization to help facilitate communication. And we're going to circle back on that towards the end as well. So one of the panelists today had actually asked me in our preliminary meetings, what is Epic anyways? Because you keep talking about it and I don't know what it is because we don't have that. So what Epic describes themselves as is their EHR, or their electronic health records, chronicle the story of a patient's healthcare over time. And what you can see is that the patient is at the center with multiple modules that surround this patient. So many EHRs are set up in exactly the same way. Patient is at the center of a single comprehensive medical record, and you may have multiple modules that interact with that patient, whether it's inpatient, outpatient, revenue, and so forth. In fact, you may have Cerner for inpatient, Meditech for outpatient. It just sort of depends on where your facility is headed with their EHR. In the case of these EHRs, depending on that facility, you may have multiple modules and you may also have third-party modules. So for those who are in an inpatient setting, you probably have some food service system database that receives admission, discharge, transfer information from the EHR. It receives food allergies, it receives diet orders, supplement orders, and so forth, so that you're able to prepare a customized menu for the patient and provide food that's safe for them to eat. So that's just a little overview, 30,000-foot view of the EHR and how we might be using it. But when it comes to documentation, we need to be able to differentiate the types of data that are actually available to us, how that data can be used to structure our documentation, and how it is searched or queried within the medical record and within the report building process. So the two big types of data here are structured data and string data or free text data. What structured data is it's easily managed and searched, arranged in rows and columns. Think about your lab results, test results, and then physical measures such as height, weight, and so forth. Free text data is more like a story. It's a conversation. It's data that cannot be really queried within a medical record, besides maybe using the keystrokes Control F or looking for a specific keyword within a search bar. It really is that narrative story part of the documentation. So when we take structured data elements and we put them all together, we can develop a template. And that template is used to generate a note and to generate forms that can be used internal or external. Before we end up like Dr. Stark here, I want you to see what an example is of structured data versus free text data. So at our facility, we do use a nutrition navigator to document our inpatient workflow. And what you can kind of see here is that there are multiple buttons and checkboxes. What do those represent? Well, they each are representative of an associated flowsheet row somewhere in the background of Epic, in the abyss back there, where we can instruct the EHR to display the contents of that specific row within our documentation. So for example, if we selected we're doing an initial assessment, it was a physician consult, we spent 30 minutes, and then we determined when exactly we wanted to see this patient again and save this is what it's going to show up like, very nice, neat, and organized in terms of our documentation. But what if we wanted to figure out when we want to see these patients again? We could create a clinical workload, and this would highlight here. Again, I did an initial assessment, and my next intervention date, I'm way overdue, by the way, it was July 31st. But those are ways that we can kind of set up an entire list of patients and when we need to have them seen, so we could make sure we're timely with our interventions. So now, besides generating that clinical workload, here's our notes, right? And you can already see there's a difference. Some text is highlighted in blue, some text is highlighted in pink. And what we can do is instruct that EHR to find the information we just documented on those little buttons and checkboxes to help generate our note. Take note of these differences here. The little asterisks in Epic, we refer to that as our free text. Okay, so in the free text, I might type out my recommendations for what supplements or what orders I would be recommending for a patient. And while you can search for these by using that little Control F or using your search bar, you really can't run a report on these recommendations. So if anybody wanted to run a report on how many initial assessments Maria Santini did in the last 30 days, we could, because you could use me as the user and look for that flow sheet row that I documented the initial assessment. And these are just basic examples to kind of give you a broad understanding of how some of this all works and comes together. But if you wanted to find out how many times I recommended a specific oral supplement in the last 30 days, you really can't do that if I've documented it as free text. You would have to build that data in a different way in order to be able to run a report on it. Now, what about those ambulatory or outpatient notes? What's really nice about this particular application in EHR is that once you have filed your note, you can actually look at the attribution elements, fancy word to say, like, where did this information come from? So it could be free text data, it could be templated data, or it could be some of that structured data that they gather just at the time that the patient is being checked into their visit. So what's really nice about this is that you can kind of see where this data is coming from. So hopefully this will give you a good understanding when you're going back to your notes to see where things come from. I had a lot of questions on the survey. I want to know how to build lab results into my notes. So let's say, for example, you wanted to do an annual note visit template and find out and introduce into that note exactly what annual labs were done for the patient. Well, you can actually build these lab results and be able to have them populate your note directly rather than having to copy and paste. But if you don't have the time to build something like that, you can easily go right to your labs. You can select them and copy and paste them right in. And it's just kind of nice because you see the reference range and you can see that data moving over time. For anyone who doesn't know me, here's a secret. I love the snipping tool. This is one of my most favorite tools within our computer systems. And if you don't know where your snipping tool is, go to your File Explorer and you can easily find it. But they know I love to grab screenshots of my labs, so I can just drop those directly into my note. And hey, who knows, maybe I might have some CGM data that I wanted to capture and put that into my note too. So this is a great and very easy tool to use. Now, what about saving some time? Because I'm running short on time as it is. So what about saving some time when we're with our patients? Well, in our EHR, we use a wrap-up or after-visit summary. In your EHR, it might be patient instructions, summary of care, continuity of care, whatever you call it. It's the instructions your patient is leaving with, right? So what I like to do is while I'm finishing up with my patient, I'm typing up all my recommendations for this between now and the next visit. And what I do is once I'm done with that, I go back to my office, finishing off my notes. I copy and paste those recommendations right to my notes so I don't have to type them twice. And then at the next visit, what I'm doing is I'm actually updating progress towards those recommendations, progress towards the goals that we made at that particular clinic visit. So here's what a wrap-up might look like. This was for an infant transitioning over to whole milk. And when they came back for their follow-up visit, what I did was I just added the date in bold and added my updates and progress towards achieving some of those goals. You may also find the ability to, create these smart phrases within your particular EHR. In Epic, they are called smart phrases. But if you have commonly used recommendations that you are using from one patient over and over and over again, it's like the broken record, do these things. You can certainly create these not only within your EHR, but if you don't have the capacity to do that, you can put them in Word, put them in WordPad, Notepad, so forth, and just copy and paste them to your note. And then what's great about this is it's customizable, right? So let's say it's a vegetarian patient and they don't eat bacon. I can just delete that right from my recommendations and boom, we're done. So in terms of boosting your productivity, I would say think about those specific note templates, new patient, follow-up patient. I have a note template for celiac clinic and for CF clinic, and they both stay separate because there's different recommendations that I make for both. Use your snipping tool. Ask yourself what is really pertinent to document. Do I need to put all these labs in my note? Yes or no? What's going to be the most important thing for you there? Typing up your recommendations and adding them to your note and updating them at the next visit. And then I would just say, copy and paste with caution. Use your attribution tools. While for dietitians at the present time, I don't believe that there are any billing implications to the percentage of your note that needs to be not copied, but that could be coming in the future. So how to keep track of your patient's progress over time. In our EHR, we have a specialty comment section, so I'm able to actually put in there when the annual nutrition visit was, when I last saw them, when their labs are due. What's nice about this is not only does it help me, but it helps the rest of my team too, because then they know what progress we are at with this particular patient and what needs to be completed before the end of the year. So in terms of providing some guidance on productivity tools and reports, it's almost next to impossible to give directed guidance because every single facility is doing things differently. While we love to say that there are standards and you follow this formula, everybody does things a little differently when it comes to structuring your notes. In fact, I've read about several facilities that have gotten rid of their navigators because they don't like documenting in that way, but then it makes it much more challenging to query that data. So what type of data are you looking for? Is it structured or unstructured? Is it queryable? And do we need to reformat those data elements to make them queryable? Those are all questions that you want to ask yourself while you're trying to think about how to improve productivity and also run productivity reports. And my best recommendation to you is really get to know your EHR reporting team. They are an incredible resource, but even if you don't know where to start, talk to the dietitian who's in a role just like mine. I love when people ask me questions. And Maria, how can we figure out, how many people in the inpatient setting have moderate malnutrition? Okay, great. Let's go. Let's figure this out. And we're going to run a report together. So we work on all of these things and just absolutely love when people have questions like that. So in terms of research, you can build upon or modify existing reports. Some accounts across Epic may have a tool called Slicer Dicer, which is a self-service reporting tool that allows you to kind of do some data customization. I will say it is not that easy to use, but there are plenty of YouTube videos and tutorials out there that will teach you just about anything these days, and Slicer Dicer is one of those things. Just because a report is not working, it doesn't mean it doesn't work or you can't modify it or, it's defunct. You may not have the appropriate security level to make a change. So investigate that as a potential barrier. And then building a dashboard. I would love to build a dashboard, but it's much easier said than done. It requires a lot of IT resources. And unless you're a really large department who sees a large volume of patients, they sometimes don't have the resources to allocate to that activity. But the future is really now. So if you haven't already seen these two articles in NCP, that's Nutrition in Clinical Practice, it's published by Aspen. These are a really wonderful introduction and nice overview of how artificial intelligence and AI is sort of going to be a real asset in clinical nutrition as well as critical care nutrition. So I want you to remember that there are a lot of nutrition opportunities that are going to be coming from AI, such as screening algorithms to detect malnutrition, disease and clinical risk prediction, like maybe predicting having a better way to predict the risk for refeeding on an inpatient setting. Dietary assessments and interventions by estimating nutrient content of foods using smartphone photos. And even here at Tufts in Boston, they have actually invented a tooth-mounted sensor that is able to tell us in the past 24 hours what types of foods you've eaten, macronutrients, micronutrients. I mean, who needs to do a dietary recall when you have a tooth-mounted sensor, right? So that could be like a real big asset for us in the future. But there is also precision nutrition and wearables, and thinking about all this BIA data and the CGM data and all the device integration that could potentially happen at some point in time to really help inform, what we do. And of course, there's good old ChatGPT, which is always interesting. So my recommendation here is, is this the Industrial Revolution 2.0, right? For us, and a lot of people are worried about job automation, loss, displacement. But remember that there is a risk of bias and discrimination in AI and the way these models are developed. And AI really has no accountability, cannot be responsible for its accuracy, integrity, and originality. So there's that, right? Remember that. So it's really important to make sure that you are involved in the development and validation of healthcare regulated AI, because this is going to help to minimize potential for poor system design that really can impact patient safety and compromise some ethical practices. One of the most recent informaticists that I listened to had a great webinar, and she really encouraged the dietitians in the audience and everyone really to start thinking about AI in a different way, thinking about it as your co-pilot to help support your role rather than replacing your role. So in summary, you want to be able to familiarize yourself with your EHR's capabilities. Always remember and think back to what essential data elements you need, and to stay abreast of how AI can safely be incorporated to facilitate your workflow optimization. Think about those routine tasks that you are continuously doing that could potentially be safely handled by AI. There is going to be an opportunity for that in the future, and I think it's time now to really start thinking and embracing that opportunity. Thank you all so very much. I'll take questions.
Hello. I have a little bit philosophical question. So having structured data is great, right? Because you can query it, you can use it for research. But I think looking at that data is kind of awful.
Not very friendly.
Yeah, like it's
looking.
just hard to read the notes. It doesn't really mean anything when you read it. And you obviously read a lot of notes in your clinical role. What is your approach on balancing the value of structured data, but also the burden of documenting that way?
I think there's definitely a place for structured data in terms of what you're looking to capture. So if I was looking to find out, let's say I wanted to know more about my inpatient formulary of supplements. Well, if I don't know what people are ordering, or, if there's all these miscellaneous orders, I wouldn't be able to gather that if it was always free texted. So I would create some sort of structured data template to capture that, and then that would inform what I do in practice later. So I think that's really, what you want to know is are there things that we need to know to help us make more informed decisions, and that's how we could run reports on them. That would be the reason why I would create things in a structured way.
Thanks.
But there is definitely a nice balance between structure and unstructure.
If we're spending the whole visit putting data in Epic and we don't actually look at the patient,
No, it's horrible.
We've
Yep.
lost sight of the goal, I think.
Yep, absolutely.
I've got a question about reports. That's something I'm interested in. So do you recommend reaching out to your your Epic IT people to help you get access to that? Are you able to build reports yourself once you learn how to do that, or do you have to have?
There's some reports that I can take, the skeleton report, and then modify it based on what I know I'm looking for. However, there are certain reports that you have to create from scratch, and those reports do require, at our place, we call it a service request. You put a service request in, they contact you, and sometimes I'm not really sure what I need. So we have this great tool called the consultation request. So I get to meet with somebody, I ask questions, and then they tell me, here's what you need to do. So I find that to be very helpful, and that has been extremely helpful over the years to get to know more people on the Epic team who are able to help me achieve my goals that way. Thank you all so much.
Thank you all.
Everybody up.